All right. Good afternoon, everyone. Welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operation Committee of the House of Delegates. We're glad that you all could be here, and just want to explain a little bit about the process that we're going to be working on today. We are covering only one bill, and that is House Bill 565, Health Facilities, Hospitals, Medical Debt Protection. We have had a hearing on this bill, so this is not a second hearing. This is a work session. I do not intend to vote on this bill today because I think that we still need to gather information from advocates and to make sure that we have, that we have at least heard some of the issues and concerns. And so what we'll do is take those issues and concerns and look at them, try to work through the week to see if we can come up with language that addresses them, and will get us a product that will be successful ultimately. So before we start talking about the bill specifically, I just want to let folks know that I believe this is an extremely important bill. I think this is a bill that has many, many good elements to it. And it is a part of our legislative process to consider all perspectives, to make sure that we're listening to all sides in order to create a product that will have the end result that we want, or at least come close to the end result that we want, and at the same time is not having negative impacts on others who are involved, in the advocates who are involved, or the people who are involved. This bill is about supporting, or not supporting, but reducing the financial burden on those who are less able to pay for expensive medical care. And I want to be really explicit about this. Healthcare is expensive. We can address that issue in lots of different ways, but healthcare, and not all in this bill. Healthcare is expensive. We pay, until the world changes and we have a different system of healthcare provision, we still pay our hospital bills. We still pay our doctor's bills. We still pay our medical bills. So there is, we're not talking about eliminating, responsibility for debt. And that was never the intent of the bill at all. But we are talking about making it possible for those who are most needy to be able to pay their bills if they can. I want to also remind the committee that we passed a bill last year, sorry, I don't know the number, that required hospitals to be very explicit in their information about the availability of financial assistance to all of their patients. That bill went into effect in October of 2020. 2020 was a crazy year just to begin with. So then, to begin a process like that in the late fall, we don't really have much information on what the impact of that has been. So I'm saying that because I want us to understand that bill, that preceding bill, has an impact this month. So for that reason, just wanted to make sure that folks knew where I was coming from on this bill. And before I turn it over to Erin, I want to say one more thing, and that is thank you very much to the sponsor, to the advocates, to the hospitals. You all have spent a lot of time trying to get to this and to get to a workable product. And I truly appreciate your passion and your efforts on it. I'm going to let Erin explain at a high level what the bill does, and then I'm going to ask the sponsor to say a few words, and then we will start going through the bill. So Erin Hopwood, you're going to tell us about what this bill does.
Okay, the bill alters the hospital's financial assistance policies that require hospitals to provide free medically necessary and reduced costs medically necessary care are calculated at the time of service or are updated to account for any change in financial circumstances of the patient that occurs within 240 days after the initial hospital bill is provided. The bill requires the hospital to annually submit their policy on the collection of debts to the HSCRC and adds to the requirements of the policy. The bill requires each hospital to annually submit to the HSCRC a report that contains certain data on debt collection, the reporting of bad debt, and costs of services provided not collected by hospitals. The amendments strike a provision in the bill that would have prohibited a hospital from charging interest fees on a hospital bill in excess of a certain rate. The bill requires a hospital to provide in writing to each patient who incurs medical debt information about the availability of an installment payment plan for the debt, and to provide this information to certain individuals at certain times. The amendments alter the payment plan language to require the HSCRC to develop a policy for a payment plan that includes certain information and guidelines. The amendments also strike language that would have prohibited a hospital from making a claim against an estate of a patient to collect a debt owed on a hospital bill in an amount of $1,000 or less. The bill contains provisions related to the assumption of liability for a debt owed. The bill requires a hospital to send certain written notice to a patient at least 45 days before filing an action against a patient to collect on the debt owed that contains certain information, and is accompanied by an application for financial assistance and the availability of a payment plan. A complaint from a hospital in an action to collect a debt must include an affidavit that includes certain information. The bill requires the HSCRC to prepare an annual medical debt collection report that is based on the hospital's compliance with certain provisions of the bill and is publicly available and submitted to the legislature. The bill also provides for when a hospital may not report adverse information to a consumer reporting agency, request a lien against a patient's primary residence, or file an action against a patient to collect a debt owed on a hospital bill, request a garnishment of wages, or make a claim against the estate of a deceased patient. And like Delegate Cullison said, we will walk through the bill page by page.
Delegate Charkoudian.
Sure, thank you. I just want to highlight a couple of things. Let me just start by thanking Delegate Cullison, thanking the End Medical Debt Coalition, thanking MHA and Aaron for all the work that's gone into really getting us to this place. I think there's a good bit more to do, but I appreciate everyone getting us to this place, and I'm grateful to this committee, and appreciate all my colleagues here who I know are going to help us improve this further. I want to highlight two things, if I could, that I hope you would think about as you're going through it. There were really two different pieces that we were trying to address in here. And one is sort of very low income, below 200% of poverty, eligible for free care. And if folks had a chance to see the bill you passed last year, we just got, that's House Bill 1420. We just got the HSCRC report. And what that tells us is that 60% of the uncompensated care, I think it's 60%, I don't have it right in front of me, the uncompensated care got written off of low income folks under 200%, people who would have been eligible for free care, got written off as bad debt as opposed to charity care. And so what that tells us is that really large percentage of folks who would be eligible for free care instead where the hospitals attempted to collect on them. So we don't know how far they got. We don't know if they got to a debt collection, if they got to court, where they got to. But it does tell us that the elements of this bill that are about putting in the guardrails so those folks aren't gone after in a collections way are important. But the second piece, and I feel like some of this has gotten lost in the conversation, is there's people who don't live under 200% of the poverty level, but still really struggle day to day to pay their bills. There's working families who just don't have the ability to pay a $500, even $700, $2,000 medical bill. And so I don't want to, in making sure and putting in the protections which we have for the folks who are eligible for free care, I want to make sure, and my goal has always been, that we also have these guardrails in place for folks in that very next level up, so they don't just sort of fall off the cliff because they're not eligible. Then they, could be sued in a way that would lead them to bankruptcy or really struggle to pay that bill. And so I think you'll see in here, and then even in a higher level, most of us, I couldn't pay, a $6,000 bill tomorrow if I got it. And so even people who may be relatively comfortable making sure that they aren't then thrown into financial difficulty because of a large bill. So I just wanted to highlight that because I feel like some of the conversation has gotten caught in one level or another, and really we're trying to make sure that everyone is, sort of the people don't end up financially ruined because they got sick. So there's specifics that I know we'll be speaking to and I'd like to weigh in on, but I just, if it's okay, just to offer that as the broader thought process. Thank you.
No, thank you. Thank you very much for the work on it. Okay, so then there really aren't any, we're going to go through the bill page by page. There really aren't any changes on up to page 3 of 13. So if you've got your bill in front of you, and this section, the first section here, 19-2 14.1 refers to what the financial policy should provide. And I believe most of that language is probably from the bill that we passed last year. So is there anything in that section that people had a question or concern about? Oh, let me just say, if you do have a question or concern, please use the raise hand function to signal that to me, and I will be watching for hands. And depending on your system, either if you're on a PC, it's in the participants panel. If you're on a Mac, it's in reactions. So using that raise hand. Okay, not seeing any hands on that section. Let's go to 19-2 14.2. This is the section where we're asking for HSCRC to collect data, very specific data that's going to inform the work going forward. Delegate Krebs.
Thank you, Madam Chair. Just for context, as we go through this, can either Jennifer or Brett just tell us currently, very briefly, what's done? I mean, they talked about the HSCRC report, 60% uncompensated care was written off as bad debt versus charity care. Tell me now what the hospitals do regarding bad debt and charity care and when it becomes which thing. So we know what context we're talking about this in. I know we've talked about it before, but refresh my memory.
Jennifer.
I'll ask my colleague Brett McCone to answer your question.
Thanks, Jennifer. Good afternoon, everyone, Madam Chair and members of the subcommittee. Bad debt versus charity, typically just from a process standpoint, the charity care is written off up front when we know the patient is eligible for charity care. So, I mean, it sounds simple. Bad debt is typically there are collection actions. And when that happens, and that is because after sending the statement and then working with the patient, or if the patient's non-responsive after sending the initial statement and the follow-up and the outreach for financial assistance, we typically at that point would begin follow up to collect. If we can't do that, then it would become bad debt. Hopefully, what we do is we identify that the patient's up front. If they truly can't afford to pay, then then the hospitals would immediately write those off to charity care. So in a simple way, I mean, the difference between the two is just identifying it earlier in the process to be an early out and writing it off to charity care.
And do they reach out to you, or do you reach out to them initially? I mean, who's responsible for reaching out right now?
Great. Thank you, Delegate Krebs, for your question. I think it can go both ways. And to the extent sometimes bills are sent to patients and they'll reach out to the hospital to say, hey, I got the bill. On the back of this is the information sheet. I can't afford to pay this bill. And so at that point, they'll go through a financial assistance application process with the hospital, and they'll go through the steps on that. Other times, after the initial bill is sent, if you don't pay the bill, they'll typically send a second statement. And then usually at some point, the hospital will reach out via telephone or some sort of follow-up to say, this bill is outstanding. We do have financial assistance information. We do have financial assistance that could be available for you. Please contact and help us to work through this with you. And that information is on every statement. We have to provide what's called the information sheet that's also in language, and that just makes the patient aware that there is financial assistance available.
Okay, thank you.
Okay. Okay, thank you, Delegate Krebs. So anything on the report that HSCRC, this part of the data that HSCRC is gathering? And before I go too far, I just want to let you guys know, we do have a hard stop at 4 o'clock. HGO has a voting session at 4 o'clock. So if we don't finish, we will continue another day. Seeing no hands on that section, we're going to go to page 4 of 13. And this is the section which is providing the guidelines for when the hospital can go to collection. Okay. So I wanted to address Delegate Charkoudian's question about the elimination, and I know this also came up, and thank you to the End Medical Debt Coalition for your feedback and that you sent to us. So I wanted to address the issue of the striking of reduced cost. And so there's kind of two pieces of rationale behind that from our thinking was it does extend the pool of people significantly. There is an impact, on hospital resources when we do these and these kinds of reductions. And our consideration or our conversations with the hospitals have been that they are considering, it's not done yet, but they're considering raising the threshold for free care. So I was thinking it would be good for them to have the opportunity to do that before we mandated the reduced cost care. So that's the rationale behind taking the reduced cost care out of where most of the sections where it occurs. Any questions or concerns about this part then, other than that one, which the delegate has already raised? Delegate Lewis Young.
Thank you. This is an area that I had a question about. On my first read, I found it problematic just because of the inconsistency. Sometimes reduced cost is stricken, other times it's in, and I found myself very confused as to when it belongs in and when it should be out. And then after thinking about it further and reading some of the correspondence, I certainly agreed with the concern that by taking out the phrase or reduce cost, you are eliminating a significant portion of the very needy population that needs some extra time and protection and assistance. So I'd have to see something concrete before I'd be comfortable removing the reduced cost language. And I'd also like to better understand why it's in sometimes and why it's out sometimes.
So I'm going to answer that question, and then I'm going to ask Jennifer Whitten to respond to the first part of the question. If we've missed any places where the reduced cost, the same provision that applied to free cost applies to reduced cost, then that's an error. We were trying to take that out and limit it to free, those who were eligible for free cost. The only place where it does apply is where we've said that there's a prohibition on the garnishment of wages. So reduced cost, anyone who is eligible for reduced cost care would not be at risk of having their wages garnished. We did keep that in there. Jennifer, you want to speak to why we took out why we took out the reduced cost care?
Yeah. Thank you, Delegate Colson. Thank you, Delegate Lewis Young. Just a little bit of context here, and it kind of also goes back to Delegate Krebs' question. So just as a reminder, the bill before you really is looking at the provisions and the reforms as it relates to the collection practices. So this is after a pretty extensive, lengthy process identifying financial assistance. So at that point, we would have identified, hopefully, that someone has qualified for free care or reduced care. Reduced care could mean that, based on that individual circumstance and payment ability, there might be a potential to pay back some of the amount that's owed. And so I think that was partly why, when going through this provision, we wanted some flexibility to think about the provision as it relates to reduced care. But clearly, anyone with who qualifies for free care would not be held to any of these standards. So hopefully that provides some perspective.
Okay. Delegate Carr.
Thank you, Madam Chair. So I'm just looking at on page 3 where it defines, free care versus reduced cost care. And it says reduced cost medically necessary care to provide low-income patients with family income above 200% of the federal poverty level. So I'm assuming that the federal poverty level is something that is the same across the entire state of Maryland, correct?
Yes.
And then there's language there that says, in accordance with the mission and service area of the hospital. So it kind of includes some flexibility to take into account the local conditions. And so one concern I have is, someone living at 201% of the poverty level in Garrett County, it has a very different standard of living to someone who is at 201% of the poverty level in Prince George's County or Montgomery County, where the cost of living is dramatically higher. So I see that by cutting out reduced cost care, we are dramatically disadvantaging those people who live in the high cost areas as compared to the low cost areas of the state.
Okay. All right. It's a good point, Delegate. I will say, though, just sort of to explain, one of the things that this bill does is it describes the process by which a payment plan can be developed. And we're going to get to that a little bit later. And that payment plan is supposed to take into consideration the financial burden on the individual. And so to the extent possible, that's what would happen in those instances with those folks who are just above that 200% federal poverty level. So just know that it wasn't like we weren't thinking about that, but we were thinking about, how to, where it can be paid, it can be paid in a reasonable and unburdensome way. I've got Ashley Black.
Yes, thank you. I'm not sure if I need to say this, I'm from Public Justice Center and a member of the End Medical Debt Coalition. I just wanted to raise and add on to the points that have already been made. I know Delegate Charkoudian already talked about HFCRC's study. About 60% of individuals who were sued were eligible for free or reduced cost care. But I also wanted to raise, by removing reduced cost care, just for consideration, a family of 3 with an income of $44,000 wouldn't be eligible then for any of the assistance or protections of the bill. And we know that medical debt can devastate a family's financial stability. So if they're already hanging on by a thread, it could be very difficult for them without these protections.
Thank you. Yeah. Okay. Any other issues people want to raise on page 4? Delegate Krebs, is your hand up? Delegate Krebs, I can't hear you.
Oh, sorry. The HSCRC had asked for an amendment on line 24. The total dollar amount of the cost, and they suggested we say charges versus costs. Maybe someone here from the HSCRC could explain why they want that.
Megan?
You do read your
Yes.
testimony, Megan.
Yeah, so under our all-payer model for hospitals, HSCRC sets the charges for hospitals. Those charges in our statute are closely tied, there's a language in our statute about the relationship between those charges and costs. And I think from what I had understood from some email correspondence with the sponsor early before this was introduced, was that this language came from places in other states. There's large differentials between the amount that people pay depending on their source of payment, right? So Medicaid, in most states, Medicaid would pay the least, followed by Medicare and then private insurance. And sometimes this self-pay people, at least historically before the Affordable Care Act, could be well above that. That is not true in Maryland. For the most HSC sets charges for payers, they are all very close together, and those charges also apply to self-pay individuals. And so we wanted to suggest using charges rather than costs, because that's consistent with our model and how hospitals are paid. But also we don't in the state have the large difference between costs and charges. And to the extent that we do have differences, it's because we at the state level have made policy decisions to build things into charges that apply to everybody.
And I would suggest maybe just change the word cost to charges if that's okay. And while I have Megan, I just had one more question for Megan while we're on this subject.
Yes.
With regard to uncompensated care, obviously you just mentioned about how we're the only state that's different with how we do uncompensated care and gets into the rate system. Will this report tell us how it's going to affect the uncompensated care and how that's going to affect our rate setting? Not to jeopardize the waiver?
The report at the end of this bill?
Yeah, no, the report here, the collecting of this is the collection of data we're looking at now. I guess this is more about race and gender and stuff than the.
Right. So this is what the hospitals have to report to us, and then we post on the website. There's a separate provision near the end of the bill about what we need to report to you.
Okay.
So I think those can be the same conversation or can be different conversations. We were asking for it to be the same. Yes. So I think the question you are asking is based on the information hospitals are required to report. Would that give us what we need to understand the impact of this bill on total cost of care? I'm going to have to think about that for a minute. I'll get back to you.
And then while you're thinking about it, if you have this information for later, I'd like to know what the total uncompensated care is now that is built into the rates per policy versus what it was before, if you know what it was before its high point before we went to the Affordable Care Act. Because we used to have that conversation a lot and now we don't have it. So I'm just trying to get a feel for how we've reined it in. So,
okay.
Thank you.
Yep.
Sorry for the noise in the background. Delegate Sub.
Thank you, Madam Chairman. So piggyback on the charges versus costs. So when you write off uncompensated care, are you writing off the charges that you bill or is what you would have collected under the contractual agreement that you have with the insurance companies? Like I'm just trying to understand the difference between the when you say cost versus charges.
Megan, you want to respond to that?
Yeah, so we set the rates that private insurance pays for hospitals. So there isn't a negotiated rate in the hospital setting.
Well, I mean, the set prices, you're right, the set prices. So what would appear on the contract or the bill is the charge that's already set for those services.
Yes.
Okay, thank you. Thank you.
Okay, thank you all very much. Now we're going to move to page 5 of Any questions on this page? Delegate Lewis Young.
Yes, thank you, Madam Chair. My concern on this page is the removal of lines 16 through 26. I thought that language was rather good. It sets a cap on interest charges. Without setting some kind of definition or cap, people could be subject to usury fees. In fact, that's why credit cards in most states have caps on the interest rates they're allowed to charge to prevent from usury fees. I mean, I don't know what the right thing should be, prime, 2 points over prime, or the language that was originally here. But I think we need to define some kind of a cap, or it's too open to unintended consequences.
Delegate, I'd ask you to look at page 6 of 13 and the policy that the HSCRC is going to develop for payment plans. Down in number 5 includes the determination of possible interest payments for patients who do not qualify for free care. So that's where that section was captured.
Okay, it's very unclear though. So the HSCRC is going to be determining interest rate caps.
What HSCRC is going to be doing is it's going to be developing a policy with guidelines that say this is what you have to take into consideration when you are setting interest fees, other fees, and setting up the payment plan.
Okay.
Delegate Charkoudian.
Thank you, Madam Vice Chair. I just want to make sure that I understand this, because when I wrote this section here, I intended it for it to be a protection on interest rates charged outside of the context of payment plans. So if I don't enter into a payment plan with a hospital, I would still get a bill. And then if I don't pay it, I would get interest, I would get late fees, and that would sort of build up over time. And so this section was supposed to put guidelines around how that could happen. And the next section, as I understand it, puts guidelines around how a payment plan is done. And so if your intention in the amendment was to take this section and sort of delegate it to the commission, I just think it needs its own separate section, because right now it looks like the only guidelines that the commission is putting into place are those if a patient has a payment plan, but there's still no guidelines for a bill in which a patient doesn't have a payment plan, but which is late and potentially racking up fees and interest. And I don't know if I'm misunderstanding, like if we're trying to do the same thing, or if your intention was to delegate that to the commission. I just think we may need some additional language.
And I'm hearing that, so we can take that under advisement.
Thank you.
Delegate Charles.
Thanks, Madam Chair. My question is in regards to HSCRCs, the fact that they're going to be the only ones pulling together the guidelines. Will we have anybody that's there that'll take people's issues into consideration, such as the folks who can't actually afford it? I would hate for HSCRC to be only persons there making a guideline list in play that leaves folks out there still having some of the same problems they had prior to.
Megan, do you want to address that?
I mean, I think generally HSCRC, when developing policies, has a fairly transparent process that involves stakeholders. I'm I still need to go back and talk some more with our subject matter experts and the folks who would be developing this policy about how that would work for us. So I don't have the exact answer, but generally we involve stakeholders in our policy development.
And if I'm correct, Megan, your consideration of policy and in other parts of the statute does address the issue of financial hardship. Is that right? Yeah. So
Yeah,
there's
we actually already have some regulations around financial hardship.
great. Thank you. We're moving to page 6 of 13. And this is where the policy actually, will be developed by HSCRC. One of the rationales for this bill was that the development of payment plans was not a uniform process across hospitals. This section is designed to develop the policy that will direct a uniform process so that every hospital will operate in the same way with the same kinds of considerations. So that's what we attempted to do in this section below line 22 on page 6 of 13. And it goes on to the next page. Questions, concerns about this part? Delegate Carr.
Thank you, Madam Chair. I guess my question is about the very last line on page 6, which spills over onto the second part of page 6. So is it saying that you have to, hospital has to show that it tried to establish a payment plan before filing a suit in court, but crossed out is files an action to collect a debt owed on a hospital bill by patient. So I guess that means like sending it to a debt collection company. And I guess why would we strike that last line on the bill?
This is, and I'm going to answer this, but I'm going to look to Jen or Brett to correct me if I'm wrong. The debt collection company often provides the services to the hospitals to do the financial assistance assessment. So that's why this language isn't there. They sometimes use those services of those agencies. It's not, it doesn't, it doesn't change their practice. It just indicates that, they're using the agency for a different reason or an additional reason. Jen, do you have any?
Yeah, thanks, Delegate Collison and Delegate Carr. I appreciate the question. So I think Delegate Collison articulated that right. So if many of you recall the briefing that we provided in November, we had Ms. Godley Davis attend with us. So hospitals do work with outside agencies that do support. They serve as pretty much an extension of staff, and their focus really is doing that outreach to determine financial assistance, again, and to work with patients based on their unique circumstances. So at any point along this process, we want to make sure that if someone's circumstances should change, that they can, again, be either qualified for financial assistance or work on that payment plan option. So by removing the ability to work with those outside agencies, it really does limit hospitals' ability to provide, I think, that full wraparound services for individuals and working with them on their certain circumstances. I will note that later in the bill, you will see more provisions around additional notification. And I think that will be important, as there's going to be several steps along this process, providing notification and the ability to set up payment plans. So hopefully that answered your question.
Does that answer your question? Okay, then I'm going to Delegate Lewis Young.
Thank you, Madam Chair. Again, a whole section was eliminated that I thought was rather good. Line 6 through 22 on page 6, I think really promoted both transparency and uniformity. I'm going to guess that it's a similar answer, that it was felt that this is covered elsewhere through the commission, but it just seems like that adds an extra layer of something that's been covered already. So I'm trying to understand the rationale for removing this.
So the difference is the language that's deleted was setting the absolutes, was setting how things had to be done. The language that is in the HSCRC requirement to develop the policy provides some flexibility so that you could actually, you have a range of options that you can look at if you are a hospital trying to create a payment plan. So we were trying to give some flexibility in the development of the policy that respected the needs of the individual as much as the needs of the institution. I'm going to go to Meg.
Thank you. So I just wanted to say that I'm still waiting for some input from our subject matter experts here at HSCRC. So I don't have any feedback on this provision today, but given that it's new, I may have feedback in the next day or so.
Thank you. Is it Bridge? Bridge?
Yes.
Okay.
Thank you so much, Delegate Cullison, for bringing all of the stakeholders to the table and for your leadership. End Medical Debt Maryland would like to request the restoration of lines 6 through 22, which would implement the income-based repayment plan. We are in a pandemic. This is urgent. We have to act now. We cannot wait for further guidelines to be developed. And this bill, with those lines 6 for 22, provides those guidelines. 5% of a patient's monthly income is fair to the patient and is not detrimental to the hospital. So I also want to reiterate that the reason it needs to be standardized and not per hospital and per region, we'll use a hypothetical example. If I am walking across the street and a drunk driver blows a red light, hits me, runs me over, I have to be rushed to the hospital immediately. I'm not going to sit there and Google, am I going to get a better income-based repayment plan if I go to Hopkins or if I go to UMS? Because I'm in serious need of medical care that is urgent. So that is why it's important that it is standardized. And we do respect the need for compromise. That's why we are here. That is why we have compromised over the course of the last 2 years. But this income-based repayment plan, not to exceed 5% of the patient's monthly income during a pandemic, is absolutely critical. So I respectfully ask that be put back into the bill. And I also agree with Delegate Lewis Young's comments as well.
I would just point out that the 5% cap on interest is in the bill in this reprint. And with respect to the example, if it's not about hospital shopping, it's about making sure that it is your financial ability to pay that is a major part of the consideration. And that's what we're trying to do with this policy, is make sure that the policy reflects the person's ability to pay. If we put a 5% cap in, then the inclination is to always have it be at 5%, regardless of what the financial hardship might be. Whereas if you put the flexibility into the payment plan, then the patient is going to be working with the hospital to say, this is what I can afford. This is what my income is. This is what we need to work out. And that development of a policy of how that will work is, I think, a really important aspect. I'm going to Marceline White.
Good afternoon, Chair Collison. Thank you again for your leadership and to everyone for coming together on this important piece of legislation. I will not echo, but I simply will underscore I support what Bridge DeMay said and also Delegate Lewis Young. I do want to raise a question and then also a comment. One of our concerns because of the pandemic is the timeline that it would take for HSCRC to promulgate a study and regulations to create some kind of payment plan, because as we know, 39 million Americans have lost employer-based insurance and thousands of Marylanders have lost their jobs. So we are in a place where people who a year ago may not have needed certain kinds of assistance do so now. So I do want to just raise that point that we are very concerned about an extended timeline to create such a plan. I recognize the concerns involved, but to your point, Delegate Collison, one thing that we're very concerned about in the new proposed regulations are under 3.3.1 may not exceed 5% of the individual's patient's federal or state adjusted gross monthly income unless mutually agreed upon by the patient and hospital is very troubling to us. From the work we've done on debt collection and the work other colleagues of mine see, oftentimes right now the debt collectors are very coercive and they will demand a much higher payment than an individual can afford. And I think that section and that line really opens up a system to create an exploitative relationship where someone is being told they're going to be sued if they don't pay an amount above what they can pay, which is what we see now. So I strongly ask that that be stricken if you do move forward with this process rather than just putting in the clear guidelines of the 5% now. Thank you.
Thank you. I have Delegate Charles, Delegate Bandari, and Bridge again, and we're going to take those three, and then I'm afraid we are going to have to stop. We will reconvene as soon as Aaron and I can figure out a time to continue going through the bill. I suspected it was going to be slow, but just time. I want to take the time and do it right. So let me go to Delegate Charles.
Thank you, Delegate Cullison. And I appreciate your explanation of setting the guidelines. So this question is really for Megan, I believe, in regards to when HSCRC does the guideline development. And I appreciate the ability to go from 5%, because you got folks who are on unemployment sometimes. You lose your job, you're on unemployment. 5% of your unemployment, which is already literally about 20% of what you typically make if you're getting the maximum amount. Will you guys be writing something in that drops it down to 1% or maybe no payments until someone actually gets to work? Or even in regards to if they are making a low salary, 5% of a low salary is a lot of money. So are you guys going to put flexibility in there and drop it down to 1% or 0.5%?
So I can't speak to what we would do because I still haven't talked to my subject matter experts about this wording. They're reviewing it now, and this wording didn't come from us. But I would say we do, when we're developing new guidelines and policies, get stakeholders together in a room, not in a room right now, but on a Zoom, and talk to them about their positions. And then once we think we've worked through the work group, we think we've come to something that is close to final, we present it to our commissioners as draft at one of our monthly commission meetings, and then we open it up for public comment and then review that before finalizing. So we have a multi-step process that involves stakeholders, and I hope that would get us to the right place if this is the direction the legislature decides to go as far as this language.
And I would remind the committee that the bill is sensitive to changes in financial status. So a payment plan could be developed, but if a person's financial status changed, they go back to the hospital to rework a payment plan as necessary. And so just know that is fully operational in this bill. So I have Delegate Bandari.
Thank you, Madam Chair. As I was reading the bill, I don't expect the answer right now, though. We are meeting again. So on page 6, line 23, it says a patient shall be deemed to be compliant with a 24 payment plan if the payment makes at least 11 scheduled monthly. That is kind of 90%. During this time, I don't think it might be feasible. We are talking about someone who are already vulnerable. So I think we can consider that at least during this time, they don't have a job. It's like if you divide that is 90% compliant, that so that's just my thinking.
Right, and I bring your attention, Delegate, to the next line where it says if they miss a payment, they can work with the hospital to figure that out. So it's, again, we're trying to be responsive to changes in circumstances. Bridge.
Thank you again, Delegate Cullison, for clarifying what's happening in the bill. So I also wanted to raise in this new version, aside from the 6 to 22 that was omitted, where it says may not exceed 5% of the individual patient's income. That's fantastic. If hospitals want it to be lower than 5%, that's also great. But the language that is concerning is unless mutually agreed upon by the patient and by the hospital. So I would just like to draw some attention to the power imbalances in the room there, and the fact that patients may not be fully educated on all of their rights as patients. I know some of the lawyers who are on the call today can definitely say that many of their clients who are being pursued for medical debt should have qualified for free or reduced cost care and were not properly informed. And we know there are still people not being properly informed of and notified of their rights despite this law passing last year. So we would respectfully request that unless mutually agreed upon by the patient and the hospital is stricken. So that way the patient has their no more than 5% of the monthly income and aren't coerced by unequal power dynamics into paying more than they can actually afford.
Okay, thank you. With that, you're going to have the last word, as Lawrence O'Donnell would say. For today, we are going to reschedule this meeting or another meeting, and we'll take up from page 7. And if you have other thoughts between now and the next time, please send them along to me, email them along to me. And Megan, maybe we'll be able to have some information that you'll be able to help us out with the development of the policy. Okay. Thank you all again very much for your time and for your efforts on this. And I will look forward to meeting with you again. Take care.